Okay. And so today we're lucky enough to have Dr. Leslie here, Dr. Ken Leslie. He's an associate professor in the Department of Surgery at Western University. And he's the director of core surgery, director of surgical education, site chief of general surgery, and program director for general surgery. He won the President's Award for Physician Leadership in 2017. Dr. Leslie is also an acclaimed researcher in surgical education and a hepatobiliary pancreatic surgeon. So thank you so much for being here, Dr. Leslie. We're so happy to have
Yeah.
you. And I will pass it over to you.
Okay, can you hear me okay, Aaron?
Yes, we can. Yep, that's great.
As I told Aaron, occasionally I have internet problems in my office because the hospital really doesn't have good internet. So if I go blank, Aaron will text me and I'll reset my sound and that sort of stuff. I'll also ask Aaron to watch the chat questions along the way. And if you want to put up your hand and stop me along the way, we can stop along the way and say, listen, can you repeat that? I don't understand it. And we'll clarify some things along the way. So don't hesitate to stop me along the way. I don't mind that at all. So I think this is great. Craig's Cause is a great society, and I'm glad to be involved with it. We had the national meeting last week, and it went really well. So they're doing a lot of great things for pancreatic cancer, and our group here fully supports it, and we're thrilled to be involved. So Erin asked me to talk about pancreatic surgery. As she said, I'm a pancreatic surgeon for almost 30 years. I'm very involved with our pancreatic cancer groups and do a lot of ERCPs on top of it. In Canada, a lot of the ERCPs are done by surgeons outside of Toronto. So we're very involved with all stages of our pancreatic cancer patients along the way. So just to give you a little bit of outline that we'll touch upon, as surgeons, anatomy is really crucial to us, and the knowledge of the anatomy is what really dictates how we operate. So I'm going to give you a little primer course on anatomy so that you have a bit of an understanding about why we do what we do, and it's based on the anatomy. One or two slides about history, because it's always nice to know where we've come from. I'll talk about all the different types of surgeries, some of the names that get thrown around. And then I'll talk about how we choose to do the surgery and what surgery we choose, a bit about risk of surgery, some outcomes, and then your questions along the way. And it's great that we have a couple really good outcomes in the crowd here from Ben and Richard that they talked about so far. So when we look at the anatomy, I've got lots of different pictures. This is kind of the first overall view when we have a look in. No, going everywhere. And this is the stomach. Behind the stomach sits the pancreas. Behind the pancreas sits the aorta, which is the big blood vessel going from your heart onto your lungs. And the pancreas, I tell all my patients, looks exactly like a fillet of fish. It's as wide and as thick, and in a normal pancreas has a little pink salmon hue to it. And it runs in the upper part of the abdomen. And what we're really wanting to see, let me see if I can get my pointer, is blood supply. And this is the arterial blood supply to the pancreas. So this is the aorta, and there's two main vessels that come off the aorta to supply the intestines and the liver. In the upper, I keep losing my pointer here. This is one main artery. It's called the celiac artery. It gives the branch to the liver. So this is a crucial artery that has to be intact for survival of the liver. And SMA runs right underneath the pancreas, supplies all the intestine. So the SMA is a crucial artery that we need. Veins, of course, take the blood back to the liver. And main vein related to the pancreas is what we call the superior mesenteric vein. Goes underneath the pancreas, comes the portal vein, and then to the liver. So when we talk as a surgeon and we look at what we're going to operate on, we really need to see the relationships of the tumor to these blood vessels because they're really important. And I tell patients, as a surgeon operating on any cancer anywhere, I want the cancer in the middle and a big normal chunk of tissue around it. I don't want to cut close to the cancer edge. I want a big margin around it. And that's what makes it so difficult for pancreatic cancer, because these blood vessels limit the margin dramatically. We don't have a big area that we can take because we really need these blood vessels. If you don't have your SMA or you don't have your celiac artery or hepatic artery, then your organs won't live and you're the gutted fish in the market. So it's not a good option. So that's why the anatomy is really crucial to us. When we look at some of the history, we go back to Whipple's first completed operation in 1946, where he did a single stage. Most of the literature will say that the Whipple operation was first done in 1935, and that was true, but he basically did it in stages. He did one stage, taking the patient and taking it out, and then he went back and put them all back together again. So that's what would be credited with the first one, so almost 100 years ago. But the first single stage that we do nowadays is actually in 46, and that's who gets credit for it. And this was actually his drawing from 1946 about what things look like when he published it. And this is the stomach, and this is his pancreas. This is the common bile duct with the gallbladder. And then this is the small intestine and jejunum that's been hooked to everything. So this is kind of his original scribbling, which is a great piece of history for pancreatic surgeons. This is the art that we want in our wall. As Whipple said back then, he said, unfortunately, due to the cancer, when he operated on these, most of the patients had metastases to the liver or adjacent structures, and most of his patients were just having a palliative bypass for the obstructed bile duct or the stomach. Because, of course, going back into the early 30s and 40s, nobody had any imaging. They didn't have ultrasounds, they didn't have CAT scans. They just had a clinical presentation of jaundice, and they operated on them. And like we find today, most of his patients did not receive a Whipple because they had advanced disease. So when we talk about different types of surgery, I'll start talking about all the different names and types that we talk about. So the first one we'll talk about is the Whipple procedure. The fancy name for that is a pancreatic duodenectomy. That means that we're removing part of the pancreas and the duodenum. And it can be done in two fashions. The standard fashion that requires about 20 to 30% of the stomach removed, or the pyloric preserving. So as you go through your different operations, everybody that's had an operation would have had a pancreatic duodenectomy, and it would have been either standard or pyloric preserving. And there's lots of debate between all the surgeons what the better one is, but I'll touch about that a little bit. On top of the Whipple procedure, there's some patients that we can take part of that superior mesenteric or portal vein and put it back together again. So the vein can be reconstructed, and about 15 to 17% of all the Whipple patients will have some form of vein resection to get the cancer out. Arterial resections are much less common. You'll find it throughout the literature. It takes really special anatomy and special tumor biology to get to an arterial resection. And it certainly is a little bit more common now with the better chemotherapies and radiations that we do to allow the arteries to be sterilized, as surgeons talk about, to cut off that scar tissue and preserve the arteries. But the artery is much more important. It's very rare to do resections, but does happen. The veins, as I said, it's pretty common to have some vein work done during your Whipple procedure. For those cancers in the body and tail, the ones that go to surgery will have a distal pancreatectomy. We're going to take out the back half of the pancreas. The majority of times, the blood vessels that go to the spleen run right with the pancreas. So most of the patients will have their spleen removed. As adults, it's okay to take out the spleen. The spleen is crucially important for building antibodies to infections as youngsters. So taking out the spleen in somebody young is very concerning. But when we live 30, 50, 70 years, we've seen lots of infections and have lots of antibodies. And we do have vaccines for people that have their spleen removed. Bypass surgery is not as common in 2023 as it was in the 80s or even back in the 40s. Because we have much better imaging nowadays. We don't have as many surprises about advanced disease at time of surgery, and we have lots of endoscopic ways with stents to deal with the bile duct and duodenum that we didn't have 20 years ago. So bypass surgery still occurs, but certainly not as often as when I started almost 30 years ago. You'll see in the literature a lot about laparoscopic or minimally invasive surgery and robotic surgery for a Whipple procedure. In Canada, Montreal and London are the only two doing it. And when we get together as a lot of surgeons, it's always a contentious topic about if it's the same as an open Whipple, better or worse than an open Whipple. So we have lots of debates, and they're great at the surgical communities. Certainly, you'll see some of the high centers like the Mayo doing a lot of robotic or MIS surgery in the States. In the States, it's a different business because it is a business model and they need to take and bring patients in. So you'll see a bit more MIS there. You'll see some more in Europe and Japan, but it's slowly progressing. And right now, I'd say in a high volume center that's well experienced, which means they've done probably over 120 robotic Whipples, I would say the outcomes are very similar. The laparoscopic people hope that as we progress over the next 5 years, they're better than open surgery, like we found in a lot of the other organs we do, but time's going to tell. Other things some patients might have had in the past is there used to be a protocol where before surgery, because just like Whipple, he found a lot of advanced disease, they would do a diagnostic laparoscopy. And this was very common in the 90s, early 2000s, but you don't see it very often anymore because we do have much better imaging than in the past. But as you read information, I thought I'd just bring it out because it may still occur. It's not wrong. It's a nice, quick 1-hour case to stage for any disease so that there's less surprises during the Whipple operation. So this is the first picture, just looking at the anatomy of the pancreas. We break it into the head and uncinate. Head and uncinate are all one organ in our mind. Neck is the transition between the head and the body, and then the body and tail. So any cancer that's to the left of the neck is going to be a Whipple procedure. Anything right is going to be a distal pancreatectomy. So that's how we start off. And we see this very clearly on how we look at the CAT scans and MRIs. So this is, where's my pointer again? This is what we see, very similar to the other picture. It's just added a few structures. This is the common bile duct that runs through the head of the pancreas. And that's why the majority of patients with cancer of the head of the pancreas become jaundice, because their common bile duct runs right through the pancreas. So as a surgeon, as I said before, if there's a cancer right here, get a big chunk of normal tissue, I'm taking all that out. So we take part of the stomach, duodenum, bile duct, gallbladder, and then we put everything back together again. And I can't stress how critical it is about the vascular anatomy. We really need to know how the cancer involves the vein, so the portal vein or the SMV. We have to know how it involves the arteries. Artery, the SMA going to the intestine, and the hepatic artery going to the liver. And those are what really defines surgery for us. So I've got a few pictures of what Whipple looks like schematically. You can go online and you can see videos and a whole pile of learning tools about this. Generally, we take part of the stomach, which is over here. We take half the pancreas, which is over there. We take all the duodenum and divide it from the jejunum, and we divide common bile duct, which is the drainage tube of the liver, and take out the gallbladder, and all that comes off. Then we have to put everything back together again. And this is kind of a standard picture. It has all the other organs removed. It's a little bit more complicated in real life. The pancreas joined to the jejunum, common bile duct joined to the jejunum, and the stomach joined to the jejunum. So that's how it looks. And this is probably the easiest picture, putting them both together. On the left, or on my left, is the area that we take out: stomach, the pancreas, all of duodenum, bile duct, gallbladder. On the right is the reconstruction. So that would be a standard Whipple procedure where there was part of the stomach removed. Pyloric preserving Whipple is a little bit different. We leave all the stomach, and we've divided duodenum about 2 centimeters from what we call the pylorus. Pylorus is the valve empties between the stomach and duodenum. So all the stomach's left intact, and we've added a little portion of duodenum. And as this technique came about, most of the surgeons that advocated it said, well, the post-op function was better, less marginal ulcerations. The naysayers were always worried about not getting a good cancer resection, but a lot of studies have shown that from a cancer perspective, having a standard or a pyloric preserving Whipple, the outcomes are the same from a cancer perspective. And there's lots to say how the function is between the two. And I'll talk a bit more about that. So I've done both of these throughout my careers. And when you see the patients long-term, I think they're very similar. So I have no bias about either one way I go. But you'll find lots of surgeons with strong biases about their choices between a pyloric preserving and a standard Whipple. So then it comes to the question about how do we choose the patient for a Whipple procedure, and what are the factors that we look at? So the first thing we look at is where the cancer is in relation to the anatomy. And we talk about the cancer being resectable, borderline resectable, locally advanced, or metastatic. So when a lot of patients come to see me, they say, oh, what stage am I? And as a surgeon, that stage is going to come about after the resection and the pathology is completed. But up front, these are kind of the 4 big categories that we put in. And of course, metastatic would be considered stage 4 cancer right away. And then the other ones are going to be dependent a bit about the final pathology. Since the Whipple is a big operation, we also have to look at the health of the patient and how fit they are, or in our literature, how weak they are. Are they frail? There's a number of surgical risk calculators that I'll show you where I can put in data and predict the risk of complications for that patient. And most importantly, as in Canada now, in the 80s and 90s, there wasn't any of this centralized surgical specialty teams, and Whipples were being done at every hospital. Since the 2000s, it's all regionalized care, surgical care, which has dramatically changed the outcome of Whipple procedures. All the patients should be presented at tumor board. They all should be involved with a multidisciplinary team and multidisciplinary case conferences. So the key about pancreatic care is not just the surgeon, it's the whole team. It's a proper review by tumor board, and then deciding what the best plan of treatment for that patient is, not only surgically, but also from the oncology point of view, and also from the palliative care point of view. So it really requires a big team to do this right. So I have lots of patients come and say, oh, Dr. Leslie, I've got to choose the right hospital. And it's like, no, you've got to choose the right team. And in Canada, you don't have that choice because the teams are there, and you can't have this done in some small hospital in Nova Scotia. In the States, it's a bit different, but certainly in Canada, everything's centralized for HPB care. So when we talk about resectability, there's lots of these definitions about what a resectable cancer is, what a borderline resectable cancer is and what a locally advanced cancer is. And they all go back to that key point that I talked about in terms of the artery and veins. And depending on if there's cancer contact or involvement of the veins or arteries, that dictates if it's resectable, i.e., I can operate right away, or it's borderline resectable, which we're not going to operate right away, or locally advanced, which we're not going to operate right away. And the majority of locally advanced cancers never get resected. And as you see, there's all these criteria, and it all depends on the amount of contact and the degree of contact. And that's why it's really important to have that specialized team and multidisciplinary team, because we sit down as a group of surgeons, oncologists, and radiologists and review everything to kind of get a sense about the resectability of that case by imaging. And it seems pretty obvious that everybody should agree on this, but resectability is kind of like in the eye of the beholder. We can all see slightly different things from imaging and all come up with a different resectability criteria. And this is the one that we use most of the time, which is the NCCN guidelines. But as you talk to more groups and more surgeons, everybody defines resectability a little bit differently. So that's why it's really important to have that specialized team about what they define as resectable, borderline, or locally advanced, because depending on how you're categorized really defines what your treatment pathway will be. As I said, it all goes back to the vein. If there's localized involvement of the vein and we can resect the vein safely, that would be a resectable tumor. If there's more involvement with artery and the SMA, then that's going to be borderline or locally advanced, depending on how much involvement. So it's really important that I've been stressing the anatomy, because that's what really makes the difference. And it goes back to that concept. As a surgeon, I have to cut out the cancer with a wide margin. And in our business, when we talk about resection margins, the ideal case after a Whipple procedure is that the resection margins do not involve cancer. So we call that an R0 resection. If there's an R1 resection, that means that when the pathologist looked at it, there's microscopic cancer cells where we've resected the pancreas, and that denotes a different overall survival to you. And R1 resections, unfortunately, do happen, and our goal is always to try to get them as low as possible. When we look at patient factors, we talk about how strong and healthy the patients are to undergo it. And if you have a family member, there's some really easy ideas to get a sense about how strong they are, especially as they're getting into their late 70s and 80s. One is a timed up and go test, which is basically have them in the chair, get them to stand up, walk 10 feet, and sit back down. A healthy patient will do that in under 10 seconds. So if you have an elderly parent and you want to see how strong they are, just time them about how long it gets. And as a surgeon, I don't need to actually time the patient. I just watch them walk down the hallway, sit in a chair, get up from a chair, and I have a sense about how strong they are or how frail they are. But there's lots of ways we can score them. The other neat way to do it is a 6-minute walk test. Get them to walk for 6 minutes and see how far they go. Generally, people are walking, in that half a kilometer range in 6 minutes, and they're healthy. If they can only walk 100 meters in 6 minutes, that's a really bad sign. So it's really easy for surgeons to see how fit or strong a patient is by just simply watching them walk and sit. But we can measure it if we want. And that gives me an idea about how frail the patient is and how they'll tolerate my surgery. If we want to take it one step further, we have some really good risk calculators. And if you went into a Whipple procedure, you can do this at home to see your own risk. You can ask the surgeon to do it, but they should be able to give you a good sense. And as I'm selecting patients to say, I think that you're a good candidate for a Whipple, not only do they have to have favorable anatomy that we just talked about, they have to be strong and they have to have a good risk score. So this is the American College of Surgeons risk calculator. And this is a database of probably 100,000 more Whipples throughout North America. And there's 70 or 100 sites in Canada and, 5,000 sites in the States. And all this data has been put in for about 15 years now. So they're able to compare you to their data set. And the common things they're looking for, I put in the procedure name, which is a Whipple procedure. And then we start with your age, sex, functional status. ASA is the American Society of Anesthesia risk classification from 1 to 4. It's about, do you have any life-threatening illness? Ascites, steroids, infection, diabetes, hypertension, kidney failure, smokers, and then at the bottom is your BMI or your height and weight. We can put that in, and I standard 75-year-old female with just a bit of hypertension, not obese, and then we see what her risk scores are. And this is really built for surgeons because it's either green, yellow, or red, so it makes it really easy for us. And let me bring up my pointer here. Black bars are the average in the data set. So you can see in the average data set, Whipple for serious complications is almost 30%. Any complications, 33%. Pneumonias, 4%. Cardiac complications, 2%. An infection is very common in our business at 20%. Urinary tract infections, clots, renal failure, readmissions to hospital. You probably don't realize this, but after you get discharged, almost 20% will come back into hospital. Return to the OR, about 5% patients will get taken back to the operating room during the post-operative period. And this is what patients care about. So across North America, death of a Whipple is about 2%. As we get into our more elderly patients, discharged to a nursing home or rehab facility, about 8% go to a rehab. And as we adjust, put in older and more risk, this really goes up. And for some of my patients, when I'm discussing them in their early 80s, this really makes their decision about have a Whipple or not, because if their death rate's 5%, they don't mind that. But if they're going to a nursing home or a rehab facility, that's really impacted their quality of life. So they really don't like that. So this is, going the wrong way. So this would be another one. We now make them 81. And then suddenly you see on the scoreboard a lot more red. And the chance to discharge is 50% for a rehab facility. So if I showed this to an 81-year-old, their death rate of 4% doesn't scare them, but their loss of independence does. And they'll say, sorry, Dr. Leslie, maybe I won't have this risky surgery. So these are really good tools to help in the decision-making for the patient about if they should do the surgery or not. And it really helps us guide the patient. And then if I take that same 81-year-old and we just do a distal pancreatectomy that we always think is a slightly smaller, easier procedure, he still has complications at 81. And the death rates and everything are much lower, less than 1% death with a distal pancreatectomy compared to 2% for a Whipple. But for each patient, we're able to score them really well. And these are really helpful for the surgeon and the patient to be able to make decisions. So they're really valuable. Because as you guys know, we've had great improvement in 30-day morbidity and mortality after Whipple. When I started 30 years ago, I told all my patients there was a 5 to 7% chance of death, and now we're down to about 2 or 3%. So that's great. So there's been great improvement because of the regionalization that we've done. We're selecting patients much better. So we have improved greatly. After a Whipple procedure, we'll say the 5-year survival is 25%. So when I'm talking to that 81-year-old that has a lot of risk to surgery and has a lot of risk to loss of independence, we have to tell them how successful it is. And we know that the success rate to live after Whipple is about 25%. And when we look at those and we talk about disease-free survival, where there's no cancer back, which is kind of our holy grail that we're really aiming for, i.e. cancer-free, almost cured, we're anywhere from low of 10 to some studies up to about 16, 17%. So that's not high in the cancer world, but without surgery, it's 0. So when we're making a decision about a really risky surgery, we have to be able to say, what are the risks and what are the true benefits and what are they aiming for? Now, there's a few unicorns out there. If they're a really small tumor, T1 or T2, if there's no lymph nodes involved, if the margin's not involved, we may get up to a 40% 5-year survival. But that's not as common. And the better number is all Whipple and not subgroup of Whipples. And that's their numbers that we're sitting in. It's great to have some of these on the phone call. So not only do we have to look at the risks and the success of surgery, there's also the quality of life of this radical surgery, because we're really alternating your anatomy. We're really putting you through a lot of stuff. And people say, geez, if I survive, that's great. If I'm cured from the cancer, that's great. But how will my quality of life be? And that's important. And most of the big studies, this was from 2000, says that the quality of life scores are similar to what they expect from any surgery, and that most patients have comparable to those of a control patient and function independently, and they don't complain about their quality of life. The one little problem with all these quality of life studies is most of my Whipple patients are grateful to be alive and they don't complain, because they're the fortunate ones that have survived and are living long term. So there might be a little bias in their quality of life reporting that they underreport because they're just pleased to be one of the lucky survivors. And then this was a systematic review from 2022. And I think the key things are to know that certainly the quality of life in the first 3 months are lower. By 6 months, you return to baseline. So that pretty much tells you that to recover completely from a Whipple is somewhere in that 3 to 6 month range. So it's not just a small surgery, a quick little recovery. It takes 6 months to get your quality of life back. And a lot of people have to understand that going into the procedure. They do, as the people online will tell you, improve over that 2 to 6 months, and it's not miserable, but it's not baseline yet, and it will get there. Last thing that they talk about is, well, if I'm taking out part of the pancreas, and the pancreas controls blood sugars and digestion, how problematic is that? And generally, it's about 40% of the patients, if they weren't diabetics before, will be diabetics, and about 40% will have pancreatic insufficiency. It will need enzymes for digestion. So not everybody, so you can reassure them that, but there is that risk of becoming a new onset diabetic or having problems with digestion. So I'm pretty good on time here. So about 2 to 3% death rate. I tell all my patients, it's similar if your neighbor said, I'm having heart surgery, you'd say, geez, that's serious surgery. If he died from heart surgery, I'm not surprised, because the lay public understands that heart surgery is serious. The lay public doesn't know about a Whipple. Complications are common, 25 to 35%. 6-hour adventure for the team to put you through. The pancreatic anastomosis is our crucial anastomosis. The pancreas is not very tough and doesn't take to be sewn to very well. And it's those complications that really lead to serious infection, bleeding, repeat operation, and death. The hospital stay has improved greatly over 3 years, 30 years. 30 years ago, I tell people to be in for like at least 2 weeks, 2.5 weeks. We have some Whipple patients out at 4 or 5 days, which is great. So we've learned a lot over 30 years about hospital recovery. And then, as I said, that 2 to 6 months to get back to your quality of life. And then any patient that undergoes a Whipple, nowadays, there's maybe a 5 to 10% chance of having unresectable or metastatic disease that has not been detected by all the imaging before surgery. So I tell all my patients, if you're waking up or I'm talking to you early in the day, like 11 or 12, I'm coming with bad news. And 30 years ago, that was 25% of the time I'd do that. Now we're down to about 5%. So it's better for sure, but still realistic and life-altering and devastating for everybody when I come in to give them that news. So in summary, it's challenging surgery. A Whipple is safe. It's much better today than 30 years ago. There's good quality of life once it's done. And you cannot have a long-term chance of cure without a Whipple plus the other therapies we give. All our improvements are because of our multidisciplinary team, better surgery, better chemo, better research. So Aaron had sent me a few questions, and some of these I've answered as we've gone through the talk, and then we'll open it up. How small does the tumor have to be to operate? Obviously, the smaller the better, but as I said, the most important thing is how it's in relationship to the blood vessels and if we define it as resectable or not. If it's off the blood vessels and we define it as a resectable, doesn't matter if it's 1.5 centimeters or 3.5 centimeters, then we can operate on it. It's kind of like that real estate. It's all about location, 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 location. That's what it's really about. Is there ever surgery for people with stage 4 cancer? Yes, we've had one online. Is it common? No. Is it like winning the lottery? Yes. It does occur, and that's why you want to be involved with your multidisciplinary team. It takes a lot of chemo. It takes a lot of luck, tumor biology, but as surgeons, we'll have people that would say, well, they have just one lesion in the liver.
Sorry, Dr. Leslie, we can't hear you.
Okay, Aaron, when did it stop talking?
Right when you were saying about the stage 4 cancer, you have to have a lot of luck, and then it sort of cut out.
Okay.
Thank you. Sorry, I was just trying to text you.
Told you, I saw that.
You called it.
So we do operate on stage 4 cancer, but you do have to have a lot of luck. Yeah, for some, I think online, all the disease in the liver disappeared, which was great. But there are a few patients that will have 1 spot or 2 spots in the liver, will be really stable on chemo for 6 months, and will entertain the idea of doing a Whipple and 1 or 2 spots in the liver. It's hard to be cured of stage 4 cancer just by surgery, but we will do it. And the most important thing is that you're involved with that multidisciplinary team, whereas there's the surgeon and the oncologist, and we go back and forth and say, yeah, let's think about this and see how it responds. The worst thing as a surgeon is to do a Whipple and think it all goes well, and then 3 months after the Whipple, the first CAT scan shows diffuse disease in the liver. That's the worst scenario, because that Whipple surgery has put you through a lot of risk. It's put you through a recovery of 3 to 6 months, but it hasn't impacted your survival because the tumor has shown up so quickly in the liver. So those are the ones that we really want to try to affect and change and choose differently. Is the Whipple surgery the best option? Without a doubt, it is the best option. But as I list it, it comes with serious risks. It comes with a long recovery. And after that period of time, people can still live a good quality of life. So best option. As you all know on the line, because you're all involved in the pancreatic cancer world, unfortunately, the majority of patients I see either have locally advanced or metastatic disease and never come to surgery. The ones that come to surgery are a much smaller population than those that never come to surgery. So if you're a surgical candidate, then yes, a Whipple is the best option. Can the tumor be removed from being wrapped around the hepatic artery? This would be classified as locally advanced right off the bat. And the patient would be given chemotherapy and maybe radiation chemotherapy. As a surgeon, we would remove this occasionally, but it's not common. They have to have a good response to chemotherapy, and they would have to be able to have the cancer removed.
Basically, no.
Basically, no.
Well, you just said it.
The only time it happens, we never say no. We say give them chemo, give them radiation, and then if there's a great response, we'll see them. The great response is just like Perry in the room is a unicorn. It does occur, but generally locally advanced do not get an operation. What options are available if it returns? When the cancer returns after a Whipple procedure, it's usually not a surgical issue. It's very rare. Chemo and radiation. Very rare to have surgery after Whipple again. Because as a surgeon, we're not getting rid of all the cancer. If we can't get rid of all the cancer that we can see and make an R0 resection, we haven't impacted your overall survival. All we've done is taken out a piece, but we see cancer pop up everywhere else. So chemo. Current guidelines for chemo before and after surgery. So I tell all the patients, for the best outcome, you need surgery and chemo. And the multidisciplinary group, depending on if you're resectable or borderline resectable, will debate about sequencing. If you're borderline resectable, most of us believe that you should have chemo up front, and that can be half your FOLFIRINOX surgery, and then your other half, so a little chemo sandwich. Other groups will give all the chemo up front and then surgery. So we have lots of different ways of doing it. When we talk about where we're going, there's more and more groups debating strongly about more and more chemo before surgery and then surgery, as opposed to what we did 20 years ago, where everybody would get surgery first and then chemo. There's been a great push to see about neoadjuvant or chemo before surgery and the role of that. So more and more centers are giving chemo up front and then surgery, or chemo, surgery, chemo. So it's one of those moving menus, but I think that having chemo up front for pancreatic cancer patients is good. There's lots of studies that are in the realms right now, and we hope to have an answer in about 5 years about what the best sequencing should be. But for the best outcome, you need a Whipple plus chemo, and then debate about the sequencing. borderline resectable patients, I think should have chemo up front before surgery. So now I really want to open up to the group, see what I haven't answered.
That's great. That was a really wonderful presentation, Dr. Leslie. I learned so much, so thank you. We've had lots of questions coming in the chat, so maybe we can start with those. Just gonna admit that person. Sorry. For an older, weaker patient, is the so sorry, this is when you're talking about the laparoscopic endoscopy, I think, option easier to withstand and recover than open surgery?
So no, both the laparoscopic and open. The laparoscopic has smaller incisions, but if you have a complication, the complication rates are the same. And the complication rate is, as we said, 25 to 35%. So if you have a serious complication, the initial surgery doesn't make a difference. So if you're lucky to be a laparoscopic Whipple without a complication, you probably will recover quicker. And we know when we do laparoscopic bowel surgery and laparoscopic gallbladders and all that, we know that the laparoscopic patients do much better than open surgery, but the complications of all those surgeries are much smaller. So that's why there's a big benefit. In the laparoscopic world, for laparoscopic Whipples, that's where you have a big debate, because if you have a complication, which is so common in our world, then suddenly the benefit of the laparoscopic work stops.
Right, that makes sense.
What is safer, removal of the superior mesenteric vein or reconstruction during Whipple surgery?
So we have to reconstruct the vein. So we just can't cut it out and not give the superior mesenteric vein flow, because that takes all the blood flow from your intestine back to the liver. And if you don't have that blood flow going, then those intestines will get engorged and die, because the blood flow has to go somewhere. So when we do work on the superior mesenteric vein / portal vein, we're going to cut out a portion of it and put it back together again. And sometimes that reconstruction is done just with the natural vein, and sometimes it's done with either cavaric vein or some vascular synthetic material, but has to be reconstructed.
Hey, that's great. That's good to know.
Let me see. So Lisa was wondering, since we're dying anyways, wouldn't it make more sense to take out what cancer you can, even if you can't get it all? Wouldn't taking some of it out at least buy us more time?
Good. So for some cancer, so that's kind of what we call the debulking principle in cancer surgery. So in cancer surgery, when we talk about debulking, we have to know that if we debulk and not get all the cancer out, there's reasonable chemotherapy that's going to control the cancer, and there has to be reasonable biology of the tumor that's slow growing. And one of the common cancers that get debulked is ovarian cancer. So patients with ovarian cancer will go to the operating room and get 80% of it taken out and leave cancer behind, because they have reasonable chemotherapies and the biology of most ovarian cancer is a little slower. You know, people can have metastatic ovarian cancer for 4 to 8 years. So it's a little bit different. So that's why it doesn't work on pancreatic cancer, because we know that if we just debulk it, the cancer just is growing just as quickly, and we haven't made you live longer, and we've taken 3 months to recover where you're not on chemo. So debulking doesn't work in pancreatic cancer, unfortunately. There's also that belief that when I do surgery on somebody, it creates a great stress on the body. It's like being run over by a truck. And when your body's really stressed, the immune system doesn't work as well. So if there's little cancer cells, because your body is dealing with microscopic cancer cells all the time, and your immune system's killing them off. So after surgery, your immune system's not as strong, and it's not controlling these little microscopic cells as well. So most of us believe that the insult of surgery alters your immune system, so that if there is any circulating cancer cells, they're not being killed by your natural immune system. So the benefit of debulking hasn't helped you because the cancer keeps growing and probably growing a little bit quicker because we've infected your immune system. So the debulking has been tried. It's always a good area. And some cancers get debulked, but unfortunately, debulking pancreatic cancer doesn't make you live longer.
Wow, that's okay. That's really interesting. That's really well put and really understandable. So thank you. My mother-in-law had bariatric sleeve surgery 5 years ago. Does that make the surgery harder? Her tumor is on the head and she has blocked ducts right now.
If she's had a sleeve, that's okay. If she's had a Roux-en-Y, that's okay. It just, any surgery that they've previously had just adds a little bit more of operative time, but they can work around that okay.
Right.
If they've had a total gastrectomy and a pull-up for esophageal cancers, that's a little bit more difficult. Not impossible, but those are the most difficult ones. Bariatric surgery is not a problem for us.
Okay, that's great. When you have a moment, can you comment on the potential of the nanoknife procedure for pancreatic cancer?
Yeah, so nanoknife is focused radiation. It's really not a surgical knife or anything like that. What its aim is to do is basically put probes right within the tumor and fry it. So it's not a knife as we like to say as a surgeon's knife, but it's been branded really as a nano knife, but it's not a surgical type of resection. It's more probes that kind of fry the tumor.
Awesome.
But it sounds really cool.
It does.
Really cool.
I think you mentioned this. What percentage of patients become diabetic after the procedure? You said that was 40%.
Yeah, roughly 30 to 40%.
Is the probability of diabetes and pancreatic enzyme insufficiency for a distal pancreatectomy?
So it would be roughly the same. If we think about the head of the pancreas and the distal part of the pancreas, it's about this 50-50 bulk. Even though the distal part looks longer, it's thinner, and the head is bulkier and shorter. But in terms of the percentage of the pancreas, it's about half the pancreas in terms of it. So doing a distal pancreatectomy, it would still be in that kind of 30% range that you may become diabetic, or you may have, since late onset diabetes is so common in North America, if that was in your cards to come when you were 80, if you have half the pancreas, it's going to happen sooner.
Great.
If that makes sense.
What percentage have issues with stents from liver becoming blocked?
So when we put in stents into the common bile duct, that's done endoscopically with an ERCP most of the time. If the ERCP can't get it done through the endoscope, then the interventional radiologist put in a transhepatic drain through the liver and out onto a bag. So those are what we call stenting of the bile duct. It can be done endoscopically down your throat into your stomach into the duodenum, or it can be done radiologically. When it's done endoscopically, there's two types of stents that we put in. One is a plastic stent that has a lifespan of about 3 months and then needs changed. And then there's a fully expandable wall stent, which is a metal stent, which is actually titanium, high-tech titanium, that expands very similar to what they put in the heart, except bigger. And those metal stents that go in will live well over a year. So that's how we look at stenting. So the plastic ones always run into trouble. They always need changed. A metal one will get a good year before running into trouble needing repair.
That's great. My mother-in-law is fighting infections from the drains. Where does she get the best care for that? Because the hospital, where does she get the best care for that? Because the hospital isn't doing a good job and they're ceasing chemo for now. We want to get her strong for surgery, knowing the risk of no prior chemo. She is stage 2, no spread. Please speak to infections.
Yeah, so any of those drains that go in, the risk is always infection in a poorly functioning tube. and the interventional radiology tubes they put in are plastic, so that's why they have more infection. If they can change that out to a metal stent, she'll have less infection because it's bigger diameter and things flow better. And some of that's all just the technical issues about the drains. If the liver's blocked higher up, then we get into a lot of difficulties with drains. But you're correct. When you look at some of the treatment before surgery, be it drains and chemo, it's about trying to keep the patient as strong as possible to then get to the next stage. And that's the journey of all our pancreatic cancer patients, taking an insult and being strong enough for the next insult. And we knew in the old days when we did surgery, it was a big insult, and at least 40% of our patients never got strong enough for chemo. And that's a big problem. And that's why, okay, they need surgery and chemo for the best chance of outcome. But if they get too frail because of all the surgery, they never get to chemo. And that's why a few more groups are giving chemo up front, so that they're getting more chemo before surgery, but the same risk involves if they have horrible complications from the chemo, they frail and never get to surgery. So it's a huge challenge. And of course, the pancreatic cancer without any treatment is trying to make the patient frail.
That's great. Sorry, I'm getting IRE. Is that an option?
That's kind of the nano knife.
That is the nano knife. Okay, perfect.
And the nano knife doesn't give the cure. It's for borderline or locally advanced cancers. It doesn't melt it away. It controls, but doesn't get rid of it.
Okay.
Doesn't take it out.
Thanks for the info on the nano knife, kind of like gamma knife surgery. Husband had gamma knife for AVM. How much radiation, even specific radiation, as in gamma and Naomi, can one person get?
You'll have to ask the radiation guys that.
Okay.
As a surgeon, I can't, we let them play around with what they want.
Totally. What happens when the SMA/SMV become encased? Does that does that cause death by cutting off blood supply?
No, the artery is quite firm and the blood flow can work through a narrowed area. The vein can get completely blocked and the body figures out a rerouting of the system to put that blood elsewhere. So that can work around it. One of the hallmarks for us about arterial involvement is all the nerves to the abdomen run with the arteries. So if you get cancer on the arteries, you'll have cancer pain. So we always talk about the painless jaundice patient. If we see somebody with a big mass in the head of the pancreas and they have jaundice and they have pain, then they're most likely locally unresectable because they have tumor encased in the artery and the nerves run with the arteries and they have pain.
Oh, that's so interesting. About 180-degree contact with hepatic artery, the celiac artery contacted to less than 180 degrees. SMA is clear. Is this a borderline resectable case?
So that would be borderline, and we'd be putting them on neoadjuvant chemo and maybe radiation.
Great. My mother received radiation 30 to 35
Great.
GY
Yeah.
per 5 of SBRT. Are outcomes similar to nanoknife?
Yes. Still controlling the disease, not getting them resected.
Great.
And there's a little bit more SBRT being done, and a little less nanoknife because the SBRT is not as invasive, but most of the high-end machines now can really focus a high intensity radiation to a small area. So SBRT, you're seeing more of that. Last week at the meeting, we had the Sunnybrook group say they're putting them on an MRI and radiating them on this fancy new MRI machine that they only have, and there's going to be another one in Canada, and they're able to give more precise radiation to the tumor at a higher dose. So a little less nanoknife we're seeing. I'm not seeing much of it anymore. I'm seeing a lot more focused SBRT.
Oh, very cool. Okay.
Now 1 year after Whipple surgery, my husband still often has an upset stomach after he eats. Does this eventually settle down?
Is he on pancreatic enzymes or not?
Marilyn, I don't know if you wanted to comment on that. Feel free to unmute yourself. Oh, she said yes in the chat. Sorry.
Yeah. So typically, if after a year, if they're having some episode, the question is, are they on pancreatic enzymes at a high enough dose? Because sometimes they're underdosed and not taking enough. I'd recommend your PERT calculator from last week to make sure you're on high enough doses. Some people need a PPI because it's acid problems, or sulfate because of the bile going past it. So there's some physical things about how we reconstruct it that can be treated that way. And then some people, no matter what medications we give them, kind of have that residual, my gut's not perfect. And I say, well, as long as you're keeping your weight up, that's really important. And yeah, it's kind of frustrating that you kind of have some indigestion. But the PERT calculator, having enough enzymes, a PPI, maybe some sulfate because of the acid bath in there. Sometimes they need an endoscopy to rule out ulcer disease where anastomosis is. And if all those things are ruled out, then unfortunately, after a year, you're always going to be like that. But you have to keep your weight up. Bad sign if you can't keep weight up.
Okay. Can patients do anything with diet or lifestyle to help their chance of getting surgery or recovering from it?
Sure, that's a really good question. So in the literature, there's a lot of talk about prehab. So we know about rehab after surgery. And there's a lot of programs talking about rehabilitation before surgery. And rehabilitation before surgery includes things like stop smoking, proper nutrition, pancreatic enzymes, and exercise programs. And some centers have really good prehab programs because we want to take that frail patient and make them a little stronger. And the obvious ones are smoking, drinking, diet, pancreatic enzymes, and then an exercise program. And we don't have a good prehab program here, but generally I tell all my patients, if you're going to go into a 6-hour surgery, that's like asking you tomorrow to run half a marathon. And if you're sitting on the couch today and running half a marathon tomorrow, that's not going to go well. And in our Canadian system, as opposed to the States, I'm going to operate on you in, let's say, 4 weeks. And that's pretty good. And I'll say, listen, you have to do an exercise program. And an exercise program means that you're measuring it and tracking it. So I'll say, listen, walk around the block, be it a kilometer or two in 20 minutes, and you're going to record that. You're going to do that for 3 days. And then you're going to say, now I'm going to go further or faster or do more steps. And you record that. So you're setting a goal, measuring it, and meeting that goal. And then every 3 to 5 days, increasing that goal. But an exercise program is not just saying, well, get off the couch and do something. It's actually measuring it, setting a goal, and remeasuring it. So some people like distance, some people like time, some people like steps. But it's not just getting active. It's actually being active, riding a bike for so long. And that's what all the prehab programs are. It's about doing that. And if you want to test yourself, go back to those timed up and go or 6-minute walk. And it's like, okay, if my timed up and go or my 6-minute walk isn't within what it should be, that's a sign I'm not in a good shape. But I don't have a good prehab program. There's huge value in prehab programs for major surgery. But it does take a lot of resources, and most Canadian centers, Montreal has a good one at one of their hospitals. not sure any other ones across Canada do. If you're in the States and you're at a good hospital, they should have a good prehab program because it's for all surgical patients, decreases complications, thus it saves the insurance company money. So they'll invest in things that save money.
Right.
So more programs in the States for prehab, as we call it.
Yeah, and I know in Nova Scotia too, one of the grant winners from last weekend, she is starting a exercise program
Yeah.
there in Nova Scotia. And I know one of the attendees here, I don't want to say their name just in case they don't want me to, but he's attending it as well.
Correct.
Yeah, so definitely that's great. If you're too weak for chemo, is radiation before surgery recommended?
So radiation is recommended for locally advanced tumors because most of those aren't getting surgery. And that's going to give another control of treatment. If you're too weak for surgery, then it's like, okay, can we give you more chemo or can we give you radiation? Because if you're too weak for surgery, you're in this palliative zone where it's like, okay, we can't resect you. Then it's what else can we give to control the cancer and give you some longevity benefit without too much side effects. So some would get radiation, some would get change in chemo. They might go from their FOLFIRINOX to gemabraxane, a little switch to see about their side effects, decrease the dose of it. But yes, they try something else to get some longevity without making them more frail and losing quality of life.
That's great. And are you doing okay on time, Dr. Leslie? I don't want to
Oh
keep you.
yeah.
Yeah, okay, awesome. There's just a few more questions here. Let's see. With a lower C19-9 count after surgery, will that increase your life expectancy, i.e. percentage go up? Or sorry, example, your percentage goes up.
Yeah, so CA19-9 is a really interesting tumor marker. We use it not to diagnose the cancer because we can't go, the best thing that we could figure out for pancreatic cancer is early detection. We've seen that in breast cancer with mammograms. We've seen that in cervical cancer with pap smears. And a good screening test means that we can give it to the whole population and it has a high sensitivity to detect the cancer and it has a low negative where it's positive, but there's no cancer. So that's the ideal test. And if we find pancreatic cancer or any cancer earlier, they will have a better outcome. And the big win in breast cancer and cervical cancer wasn't from surgery or better chemo, it's from earlier detection. And they've done it greatly. So we need some smart little 25-year-old to figure out early detection. And that's the holy grail in the business. So we know CA19-9 is not a good early detector marker. If we put it to the whole population, we're not finding the cancers early. We know that there's some cancer of the pancreas patients that don't secrete CA19-9. So for some patients, 10% in that range, even though they have cancer everywhere, the CA19-9 doesn't go up. They don't make it. So we know for some patients, it's not a good test. We know it's very good as a monitor. So let's say you have before surgery, your CA19-9's 300, you have surgery, it goes down to 20. Over the next year, they're following you, it's low, and then it goes up to 600. We know that that's a good treatment marker. So it's not necessarily prognostic, but it's certainly very good for monitoring along. The most important thing about the resection and the prognosis is what I talked about earlier. Is it a tiny tumor, T1, T2? Is it node negative? And was the resection margin negative? Those ones will do better because that's the final stage of that cancer.
Okay, that's great. That's good to know. Definitely need somebody smart to come along to make that screening process.
Yeah.
Is a pyloric preservation approach taken in an attempt to help? Oops, sorry, the question jumped. Is a pyloric preservation approach taken in an attempt to help qualify or sorry, to help quality of life with eating and feeling of fullness.
Yeah, the ones that truly believe in a pyloric preserving, they think that they have better function, gastric and eating long term. The downside is the oncology outcome is the same. So you have a small group of patients that have lived long term with either operation, as opposed to if we had 90% surgical success, we'd be able to say, because then we'd be able to do a huge study and say, yes, definitely a pyloric preserving at 5 years has a better quality of life than a standard Whipple. But most of the quality of life ones are a mixture, and people would say, yeah, they might function and have a little less GI effect.
Got it. Okay. So Marilyn said, who do we see for aftercare?
You hear me again?
We can hear you.
Oh, in terms of long-term follow-up, it's that concept of you had the multidisciplinary team before the surgery and making decisions about the chemo and all that and the surgery, and the post-op, the same thing. Where's the role of chemo and surgery? And depending on how the center's set up, it could be multiple members of the team following you long-term, or
Sorry, we lost you again, Dr. Leslie.
saw your mouth move.
Yep, now we can hear you again.
There has to be
Heard up to multiple members of the team might follow
Yeah.
you.
So at least one or multiple have to follow you long term. Because we're looking for a number of things. We're looking for recurrence, because we know that occurs frequently. We know that there's quality of life issues, GI issues, diabetes that needs to be followed. Taking out the duodenum, there's some problems with vitamins and fat soluble vitamins and B12 that need to kind of be followed long term. So you kind of need the team. The downside of our cancer system is that sometimes the oncology programs are so busy that they say, well, follow-up gets discharged to their family physician. And that's a little bit of a downside of our system, because not a lot of programs have a good long-term follow-up wellness program for any of their cancers, because we don't have enough resources at our cancer clinic to deal with all the new ones and all the ones in recovery. So theoretically, for pancreatic cancer, it's such a small group of patients that they should still be continue to be followed by one of their pancreatic cancer specialists and not discharged to their family doctor. But I realize each little program is going to have their constrictions that they can do and not do. It's very common in the breast cancer world, where the multidisciplinary specialized teams discharge them to their family physicians for two reasons: is that there's many more breast cancer patients than pancreatic cancer patients, and it's a different disease biology. They're at like, I think 85-90% 5-year survival now. We dream for that for pancreatic cancer, but that's where they're at. So I hope that answered it. So my hope is that within Canada, somebody from your specialized team is still following you.
Okay, thank you.
Great. Pancreatic cancer screening, is a Gallery test worth looking for?
There's lots in the literature. Nothing is good yet. Last week at our meeting, we had George Zopoulos from Montreal talk about high risk patients that are getting screened, and they're in an international study trying to get 10,000 patients to figure out what the best screening is for that subgroup of patients. And that's fancy things like MRIs, endoscopic ultrasounds, genetic testing, but they know that everything they have right now is not applicable to the general population. It's more about a high risk. So 2 members of your family have pancreatic cancer, they would consider you high risk.
Right. Okay, that's great. If CA 19-9 is going up, but only slightly from blood test to blood test, still within the 40s over the past few months, but upward trend, is that a red flag?
No, that's still okay. If it's kind of in that sub 100 range and just bouncing around, that's okay. What we don't want to see is that it goes from 30 to 60 to 120 to 340 to 1,000. So that's an exponential growth as opposed to this little bouncing around in the 40, 50, 60 range.
You made Sam quite happy. She said, "Yay!" And then I have one more question here. How can we disseminate best practices of post-op and long-term care for patients after discharge?
So some of that comes from these advocacy groups that bring people together. A lot of the programs have certain pathways built in for prehab. They'll have pathways built in for recovery during their surgical procedure. And then it's more than building in pathways for the right follow-up. The downside with some of the follow-up is, where does it start? Because as I said, there's surgery, there's chemo, there's radiation, and it's like, when are you outside of all the insults we give you, and where does follow-up start? Because for most of the patients, if you think about it, you've got 6 months of chemo, you got 3 months of surgery, you're at 9 months, another 3 months of recovery. It's like a whole year of just active treatment, never mind if you have a month of radiation. And then it's like, okay, where do we start from there, and how do we follow those appropriately, and what's the right sequence? And that's kind of where advocacy groups like yours come along, because it's like, okay, let's go see what all these different cancer clinics are doing and what's best practice and how to disseminate best practice follow-up. Because we have best practice for recovery after surgery, there's surgical stuff. We have really good practice to define radiology and chemo and all that sort of stuff. And groups have follow-ups. It's more advocacy groups than advocating to say, how come the follow-up at center X can't be at center Y? And that's where you guys come in and say, here, we're learning all this stuff. Center X has something really good. Maybe we can disseminate that to center Y. And that's some of the stuff we heard about last week at the conference, that dissemination.
Definitely, definitely. That's great. And sorry, one more question here. I'm seeing if there is time, since my Whipple, I get sick more often. Is that because my spleen was removed, as you mentioned earlier? Thank you so much for your time today.
So if you had a Whipple, your spleen should still be there, theoretically. If you talk about getting sick, as in GI symptoms, we would talk about enzyme replacement. If you say, I get the flu a little bit more or colds a little bit more, that's the whole immune difference that has occurred through all the insults that we've thrown at you. And depending on where you at, are, people on active chemo are more prone to infections because they're not as strong. People getting through surgery are more prone to infections and pneumonias because they're not as strong. So it's about, are you back at baseline from a strength point of view? Have the surgeons and oncologists completed all the horrible insults we give to you? And then where are you at baseline going forward? And what infections are you becoming more prone from? And yes, some of that's going to be from all the horrible stuff we do. Chemo's horrible, radiation's horrible, surgery's horrible. We do have a lot of long-term effects.
There we go. That's great. Okay, thank you so much, Dr. Leslie. That was so great. And thank you for the extended question period. That was fantastic. I think everyone got a lot of benefit from it. I'm seeing lots of things coming through the chat saying thank you. What a fantastic presentation. So thank you so much for your time today. That was really great. And yeah, we look forward to posting this on the website. I know it'll get a lot of interaction. And yeah, thank you again so much for all of your time today.
And no, I hope everybody's from different time zones. I hope it worked out well, and I think it's great for your society and advocating and having serious rare cancers, we need more voices. And I think Craig's cause and your groups are doing a great cause for that.
Awesome.
The
Thank you.
difference compared to when I started my practice 30 years ago.
Oh, that's so nice to hear. Thank you so much. And you know, we're so lucky to have doctors like you who really care and, you know, are really making a difference in the pancreatic cancer world. So thank you so much again for your time. And thank you everyone so much for attending. If anyone does have any questions that you want me to pass along to Dr. Leslie, please feel free to send them to me. My email is Erin, ERIN, @craigscause.ca. And happy to sort of facilitate any of those questions. Again, Dr. Leslie, thank you so much for your time today. And yeah, otherwise, I hope everyone enjoys their weekend.
Yeah, I agree with that, Aaron. If they have, just like when people come and see me in consultation, all the questions that they have occur when they hit the parking lot and driving home. If something comes to mind that has perked your interest, send her an email. I'll answer it.
So thank you so much. That's wonderful. All right, everyone, have a wonderful rest of your weekend.
Okay, bye-bye.
Bye.